Hello everyone. It's a real pleasure to be here with you today as part of this IOC program. My name is Dr. Mark Stewart and I'm delighted to introduce myself as your lecturer. Over the next hour or so, we will explore the world of drugs in sport, particularly the wider prohibited list, anti-doping regulations, and your role in prescribing for athletes while ensuring fair and safe competition. But before we dive into that, let me tell you a little bit about myself. I am a pharmacist by profession. I've spent my career, at the intersection of pharmacy, sports medicine, and anti-doping. As well as a pharmacy degree, I hold a PhD in sports pharmacology from University College London, alongside several other postgraduate qualifications in clinical drug dependence and botanical medicine. My journey in sports pharmacy began over 2 decades ago, where I started as a volunteer pharmacist at the Sydney 2000 Olympic Games. And since then, I've had the privilege of working at 12 Olympic Games, including as chief pharmacist for London 2012, 5 Commonwealth Games and 3 European Games at the highest level of international sport on both the medical and the anti-doping side of these games. Currently, I'm based in Lausanne, Switzerland, and I serve as the Drugs, Health and Operations Development Senior Manager at the International Testing Agency. I'm also the pharmacy expert to the IOC Health, Medical and Science Commission Games Group and on the European Olympic Committee's Medical and Anti-Doping Commission, where I advise on pharmacy operation for these events. I've also been a member of the World Anti-Doping Agency Prohibited List Expert Group since 2014, where I advise on what drugs should be banned in sport. Now, this is particularly relevant to this lecture, which focuses on the wider prohibited list, which I've been closely involved in shaping over many years. So I'm very pleased to be able to give you some insight into this process and some of the science and thinking behind the prohibited list. I wish you every success in your journey in sports medicine and in getting to grips with the complex issues relating to drug use in sport. So good luck and let's get started. Hello, and thank you for your time to listen to this presentation on understanding prohibited drugs in sport. As sports physicians, you play a vital role in both athlete health and the integrity of competition. Understanding which medications and supplements are prohibited in sport is essential to ensuring fair play while providing the best possible care for the athletes you treat. Today I want to give some context to your role as a sports physician in terms of ensuring clean sport and avoiding prohibited medications. This presentation will focus mainly on the World Anti-Doping Agency prohibited list. So please, at this point, have the current version to hand and refer to it as we go through this lecture. You can access the current version on the World Anti-Doping Agency website. Pause the video and download it now if you don't already have it in front of you. So, I will give you an overview of the legal basis behind the prohibited list, explain how the list is reviewed and updated, and outline the structure and some of the terminology used. Then I will walk through the prohibited list section by section to give you a good understanding of each class of prohibited substances and methods, why they are included, and what you as a sports physician must consider when prescribing medications to athletes under these very unique regulations. Later in the presentation, I will also cover the concepts of substances of abuse, a category within the prohibited list, plus the WADA monitoring program. And finally, how to check the status of medications that you may prescribe. As a sports physician, you have an important role in preventing athletes from taking prohibited substances, either deliberately or inadvertently. You may be closely aware of the person's dietary and lifestyle factors or of their potential use of illicit drugs. You are really in a unique position to be able to provide guidance and support within the sports setting. Now, to fulfill this role, you must fully understand the rules, the regulations, and the governance of anti-doping. Healthcare professionals, including doctors, nurses, pharmacists, physiotherapists, paramedics, may provide care or advice for an athlete and be involved in the prescribing, administration, or supply of medicines or supplements. As a physician, this role may take place in a variety of circumstances, including your everyday clinical practice, or as a healthcare provider for a sports organisation, or when you're working as part of the medical services for a team at a major sporting event, such as the Olympic Games. As a sports physician, you have a pivotal role in ensuring that athletes reach and maintain their optimal performance levels through the treatment and prevention of injury and by improving and restoring health. Integral to this is an athlete's anti-doping responsibilities and the necessary practices and behaviours that ensure that they can be clean and stay clean of doping throughout their sporting careers. As a physician working with and treating athletes, your role and responsibilities include, firstly, to understand and comply with all the anti-doping policies and rules applicable to the athletes you treat or support. You must cooperate with the athlete testing program, and also to positively influence the athletes that you care for to foster anti-doping attitudes. You must also cooperate with anti-doping organisations such as national anti-doping agencies or international sporting federations who may be investigating anti-doping rule violations. Now, in terms of the athlete's responsibilities, they have the responsibility to inform you of their obligation not to use prohibited substances and prohibited methods, and to take personal responsibility to make sure that any medical treatment that they receive does not violate any anti-doping policies and rules. Now, as a prescriber, you may refuse to prescribe or supply a medicine where there are reasonable grounds for suspecting misuse of a particular drug by an athlete, including for performance enhancement in sport. Let's briefly look at the anti-doping system and how it works. The key elements that you need to know are as follows. Firstly, WADA, the World Anti-Doping Agency. Now, this is the international independent body responsible for harmonising anti-doping policies in all sports and in all countries. The World Anti-Doping Agency was established in 1999 as an international independent agency composed and funded equally by the sport movement and various governments of the world. Now, WADA's mission is to lead a collaborative worldwide campaign for doping-free sport. And the key roles of WADA are, firstly, publishing and monitoring compliance with the World Anti-Doping Code, anti-doping program coordination and development worldwide. They support science, medicine and research in the field of anti-doping, and are responsible for education development for both athletes and athlete support personnel, who include healthcare professionals working with athletes. Now, the World Anti-Doping Code is the core document of WADA. It is a key document that lists out all of the anti-doping rules, policies, regulations for all signatories of the code. The World Anti-Doping Code is the core document that harmonises anti-doping policies, rules, regulations within sport organisations and among public authorities around the world. The anti-doping responsibilities of both athletes and also the people that work with or treat or assist athletes to prepare to compete in sports competition is contained within the World Anti-Doping Code. Now, this does include the responsibility of physicians working with athletes. To complement the code, there is a series of international standards that exist. And as a physician working with athletes, the prohibited list is the key document that you need to know and understand. It lists out all of the prohibited substances and methods in sport. To start, you also need to know that anti-doping is based on the principle of strict liability. This means that an athlete is solely responsible for everything they use and that is found in their body. And an anti-doping rule violation will occur whether or not an athlete intentionally or unintentionally used a prohibited substance. It's never an excuse for an athlete to say, "I didn't know," or "my doctor gave it to me." In the end, an athlete will always face the consequences if that substance, a prohibited substance, is found in their system. Now, this includes strict liability for any prescribed medicines or over-the-counter medicines that healthcare professionals issue or administer to athletes. And the same liability applies whether the drugs are issued by a doctor, a pharmacist, or any other healthcare provider. And because of this, you have a responsibility and duty of care to ensure that your athlete patient has all the information needed to make informed decision about their medications. I just want to take some time to describe the various anti-doping rule violations outlined by WADA that can apply to both athletes and healthcare professionals working with athletes. Now, the most obvious ones, of course, are the presence of a prohibited substance in the athlete's system, or the use of a prohibited substance. But in terms of what healthcare professionals can be sanctioned for, these include tampering with any part of the doping control process or any part of the results management, possession of a prohibited substance or method, trafficking of a prohibited substance or method, the administration or attempted administration of a prohibited substance or method, and lastly, complicity or attempted complicity in an anti-doping rule violation. Not only athletes can be sanctioned, and there can be serious sanctions for healthcare professionals in relation to anti-doping or covering up anti-doping, which may involve the following sanctions or convictions. I just want to briefly go through those. It could be loss of accreditation from the event, loss of your membership from a sporting organisation, ineligibility to work with athletes in the future, potentially criminal convictions depending on the circumstances, and loss of professional registration from your medical regulatory body. So let's dive right in and start to explore the prohibited list in detail. The prohibited list is the international standard published by the World Anti-Doping Agency that defines which substances and methods are banned in sport. Now, this includes a number of common medications that healthcare professionals should be aware of if they're working with or treating athletes. The first WADA prohibited list of substances and methods was published in 2003, and it was first implemented in 2004. It is not, however, the first ever prohibited list, as actually this was a list produced in as far back as 1968 by the International Olympic Committee, and the list was enforced from 1968 to 2003. The version we have today is much more comprehensive. It has many more examples and is growing in length with new prohibited drugs year on year. As a healthcare professional supporting athletes, it is very important that you know where to find it and are familiar with what's on it, so that you know how to check whether the medications you plan to prescribe or administer to athletes are prohibited or permitted in the sports that your athlete patients compete in. The prohibited list is a constantly evolving document, and it's updated at least annually. So it's really important that you always check for any updates. WADA publishes the version for the upcoming year in October, which comes into effect on the 1st of January. So there's a very short window to really review all of the medications of your athlete patients and to also consider whether these changes might impact your prescribing choices going forward into that next year. Very occasionally, changes to the prohibited list are made in the middle of the year at any point in your time. So if you need to take a new decision about whether to prescribe, administer, or even recommend a medication to an athlete, always refer to the WADA website for the most up-to-date and current list, so you're basing that decision on the current rules. I would also recommend that you always keep a copy of this document close to hand in your place of practice or clinic, on your desktop, on your computer, for quick reference to refer to if you are treating an athlete. So, how does a substance get onto the list? A new substance or method can be added to the prohibited list if it is deemed to meet two of the following three criteria. Firstly, that it has the potential to enhance sport performance. For example, that the substance could make the athlete run, swim, or compete faster, or for longer, or lift heavier weights, or feel less pain so they can push themselves a little harder. Secondly, that the substance or method represents a potential health risk to the athlete. Now, many of the drugs on the prohibited list actually fall into this category, based on some of the serious side effects that they have or the negative impact on health. For example, as you as a healthcare professional will know, anabolic steroids can have serious cardiac side effects, which can result in increased risk of heart attack. And some of the narcotic drugs, such as tramadol, morphine, fentanyl, have serious risk of addiction. And of course, cannabis, marijuana, the use of that has widely documented health risks for users. The last criteria is that the use of the substance or method violates the spirit of sport. Now, the spirit of sport really covers many concepts, but in essence, it is the values relating to things like ethics and fair play. And I always say that if something is being used with the intention to cheat, then it's probably going to be against the spirit of sport. Now, I would like to emphasize that these three criteria are of equal importance. And while some discussions in the past have suggested that performance enhancement should be a mandatory criterion, This proposal has never been agreed upon, and this is because experiments to prove performance enhancement could be potentially unsafe or unethical in humans, especially really for things like designer substances or unapproved drugs. And so the three criteria have remained as being of equal importance and have not changed in any of the wider code updates over the years. And so it's on this basis that the World Anti-Doping Agency Prohibited List Expert Group make their recommendations for the inclusion of substances on the prohibited list each year. There are a number of different factors that influence the evolution of the prohibited list year on year. It can, of course, be developments in scientific knowledge, and some of the research in anti-doping comes from wider research grants. There can be improvements in analytical methodologies, in emerging pharmacological breakthroughs, in the results of the wider monitoring program, in new intelligence gathering, drug seizures, and doping trends that we find out about, and in refinement of methods to distinguish permitted therapeutic uses from prohibited uses can also be considered in terms of changes to the prohibited list. Changes can also come about in response to changes in the international standards of care in medical practice or the licensing of medications. The prohibited list is overseen by the Prohibited List Expert Group, and we meet 3 times a year to review any new evidence or new drugs that come onto the market. Any revisions proposed for the prohibited list undergo a consultation period with wider stakeholders, and stakeholders include anti-doping organisations, sports federations, and this is all before the new list is published. This whole review cycle happens over the course of 1 year, with the new list coming into effect each January 1st. The prohibited list specifies when substances and methods are banned, either at all times, and then this refers to both in competition and out of competition, or only during the time of competition, and we refer to that as in competition. It also covers which substances are prohibited in specific sports. I want to briefly focus on some of the terminology of the prohibited list, its nomenclature, specifically the names of the substances included. Now, consistency in naming is crucial to ensure that the same substance is recognised and understood worldwide, no matter where the list is used. To achieve this, WADA follows the INN, or the International Non-Proprietary Name System, which is published by the World Health Organization. The INN system provides a globally accepted and standardized name for pharmaceutical substances. They don't always exist, and in the cases where an INN does not yet exist, WADA uses the IUPAC name, which follows the naming convention set by the International Union of Pure and Applied Chemistry, or IUPAC. As new INNs are generated, WADA updates the list accordingly. The newly assigned INN is added, and the previous IUPAC name may be included for a transitional period before being phased out. Now, while WADA prioritizes using the formal name of the substance for accuracy, there are instances, particularly in some of the supporting documents that they published, where it may be necessary to refer to the common name or even the street name to ensure clarity. Let me give you a simple example. If you look at section 1 of the list, you'll find a substance called nandrolone. That is its INN, but it is also commonly known as 19-nortestosterone. So by adhering to these naming conventions, WADA ensures clarity, consistency, and helps to maintain a globally standardized approach to substance classification and regulation. I want to explain some other aspects of the terminology and phrasing used in the list and why they're important. While WADA includes as many common examples as possible in each section, it is practically impossible to list every chemical analogue or biologically similar substance. In the past, doping cases have involved designer drugs, substances deliberately synthesized to bypass legal controls. This meant that every time a new substance appeared, legal documents had to be updated. So to address this, WADA uses these open categories and standard phrases such as including but not limited to, or other substances with a similar chemical structure or biological effect. Now, this approach ensures that any emerging substances, like designer drugs, whose biological effects are not fully known yet, are still covered. It also accounts for natural substances, such as plant or animal extracts, the chemical structures may not yet be precisely identified. And additionally, WADA includes references to things like metabolites and isomers throughout the list to capture all the other variants of prohibited substances that may be out there in that category. So by using this inclusive phrasing, WADA ensures that the list remains comprehensive and adaptable to any new developments in doping substances as they arise. But on the other hand, just because a drug is not named specifically on the list, it may still be prohibited. Although usually the most common examples within a class of medication will be listed. So as a sports physician, you really need to check whether the therapeutic or pharmacological class of a drug is prohibited as part of your process in considering what the status of this medication is and before you prescribe this to an athlete. The WADA code definition of specified substances is those substances particularly susceptible to unintentional anti-doping rule violations because of their general availability in medicinal products, or which are less likely to be successfully abused as doping agents. The other definition to know is that of non-specified substances. Now, these are substances that have restricted availability, are less likely to appear in medicinal products or supplements, and are more likely to be ergogenic or enhance performance. Specified substances are not less important or less dangerous, but may result in a reduced sanction if the athlete can establish that the use of such a specified substance was not intended to enhance sport performance. Now, the important thing to remember, regardless of these definitions as you see them throughout the list, that regardless of whether it's a specified or non-specified substance, the substance is still prohibited. These terms really just relate to the length of sanctions that can be applied. Now, let me give you an overview of the sections of the prohibited list. You can see a summary of the main sections on the screen. You can see that it consists of substances and methods prohibited at all times. Now that is every day of an athlete's life, including when they're not competing. It also has a section with substances, including medications, prohibited only during the in-competition time. Now this is from 11:59, the night before the event, until the end of the doping control process. The logic behind this division is because substances and methods can have long-term effects, such as growth hormone or anabolic agents, and these are more likely to be administered during the training period rather than during the competition period. While there's others that impact more directly on the competition itself and may have more of an immediate effect, such as stimulants, and because of that, these substances, such as stimulants, are prohibited only during the in-competition period. It also has a section that describes substances that are only prohibited in certain sports. Now, this currently applies to beta blockers, which are prohibited in sports such as golf and archery, where control of movement is very important for performance, and I will cover this a little bit later on. I wanted to point out a very useful section of the prohibited list, and that is simply the table of contents on the very first page. Within it, there are some common examples of medicine and medicine categories that you may prescribe, which are contained within the prohibited list. It's worth taking a read of this page to familiarise yourself with some of these categories, which you've probably prescribed to patients at some time in your career in the past. Do take some time to check this page out. It's a good summary of the categories that you need to be aware of. Let's now look at each of these categories in detail, starting with substances and methods prohibited at all times. That is both in and out of competition. For an athlete, this is every day of the week, every week of the year, literally at all times. The first section of the list is S0, non-approved substances, which was introduced in 2001. This category addresses the potential abuse of substances or methods that are not yet included in any other section of the list. S0 covers any substances that does not fall under existing categories, but has a similar chemical structure or a biological effect. It is intended to include things like drugs in development that are not yet authorized, discontinued medications, substances that are not meant for human use, potentially such as veterinary drugs, and designer drugs which are deliberately synthesized to bypass the prohibited list. It's important to remember that substances under the S0 category must still meet 2 of the 3 wider criteria for prohibition. Now, this category ensures that emerging and unregulated substances are still addressed and maintains the integrity of our anti-doping regulations. The first pharmacological class I'll be examining in detail is anabolic agents. These substances enhance anabolic processes in the body, meaning they increase protein synthesis, reduce protein breakdown, and promote muscle growth. They're divided into 2 main sections. Firstly, anabolic androgenic steroids. And this section includes many substances, but I just wanted to highlight 4 key examples in this section. Testosterone. Now this is commonly prescribed for hormone replacement therapy in men with low testosterone. It's available medically in patches, gels, and injections, and used medically for male hypogonadism and certain growth disorders. Another example is danazol, Now this is used primarily in gynecological treatments for women. And another, stanozolol, and this is used as a treatment for hereditary angioedema, which is a rare condition. The next is tetrahydrogestrinone, or THG. Now this is a designer steroid which gained notoriety in the early 2000s. It was developed at the Balco laboratory, the Bay Area Laboratory Cooperative, and supplied to professional athletes to evade doping tests. It's a very interesting case to look up and read through what happened with the Balco laboratory incident. Now, in terms of side effects of anabolic steroid abuse, these are pretty well documented, particularly in bodybuilding circles, and they include increased aggression, acne, high blood pressure, liver toxicity, elevated low-density lipoproteins, which is the bad cholesterol, heart issues, including left ventricular enlargement, and fertility problems and development of breast tissue in men. Other anabolic agents is the second category in this section. Now this category includes clenbuterol. Now this is known as an illegal growth promoter and a meat contaminant in some countries. Also in the section is selective androgen receptor modulators, or SARMs, such as ligandrol, which has been found as a contaminant in some vitamin and mineral supplements. Another example is tibolone, a licensed medication, and this is used for postmenopausal osteoporosis. And it's a hormone replacement therapy, HRT. It's also used in other gynecological conditions. Another example in this category is zilpaterol, which is a legal animal growth promoter used in countries including the United States of America. And this is sometimes found as a contaminant in some food supplements. The next section, S2. Now this is peptide hormones, growth factors, and related substances. This category includes many biotechnology-derived medicines, such as monoclonal antibodies, which were developed for conditions that previously lacked treatment. And many substances in this section are still in clinical development, rather than being widely available medicines that you might prescribe. Let's look at the erythropoiesis-stimulating agents. Now this includes erythropoietin, or EPO, and other related substances. Now, these substances stimulate red blood cell production, enhancing oxygen delivery to the tissues, which is obviously a clear advantage in endurance sports. EPO is legitimately used to treat kidney disease, chemotherapy-induced anemia, and a few other medical conditions. Other medications which are relatively new include a category of drugs called hypoxia-inducible factor, or HIF activators, which include drugs such as daprodustat, also TGF-beta inhibitors, such as sotatercept are also included. Cobalt is listed as a HIF activator, but vitamin B12, which actually contains cobalt in part as part of the molecular structure of vitamin B12, is not prohibited, as it doesn't act as a doping agent. However, supplements containing inorganic cobalt are prohibited. Some of the side effects of drugs in this category could include increased blood viscosity, leading to heart disease, stroke, potentially embolisms, and in some cases immune disorders, which have been linked to cases of doping with EPO. Moving on to another category within S2, we have gonadotropins and related hormones, which are prohibited in men only. These include substances like choriogonadotropin and luteinizing hormone, both of which are associated with increased testosterone production. Their effects can be further enhanced when combined with estrogen blockers, which I'll cover later under S4. Human choriogonadotropin, or HCG, in particular, has been reported in the popular media to be marketed as a weight loss aid, although its actual effectiveness remains uncertain. There are also drugs such as buserelin and gonadorelin, which are permitted for female fertility treatments, but prohibited for men when used in, say, oncology treatments. If used in these cases, a therapeutic use exemption, or TUE, would be required. Now, abuse of these hormones can lead to immunological issues, infertility, osteoporosis, and even psychiatric disorders. I also want to mention corticotropins and their releasing factors, as these play a key role in regulating cortisol levels. The most well-known example is corticotropin, which is a potent stimulator of adrenocorticotropic hormone, or ACTH, released from the anterior pituitary. Corticotropin itself is a short-acting and is primarily used as a diagnostic agent rather than as a therapeutic drug. However, the broader effects of this class are largely mediated through glucocorticoids, which I'll discuss in more detail when we get to section S9. Next, I want to focus on growth hormone. Growth hormone is a peptide hormone that stimulates growth and repair. It is used legitimately for growth disorders in children and adolescents, but in sport it has been abused, obviously, for its effects on reducing body fat, increasing muscle mass, and improving recovery. The performance-enhancing effects of growth hormone are largely mediated through insulin-like growth factor 1, or IGF-1, which increases the total body protein turnover and enhances tissue repair. IGF-1 is listed specifically later in the section. This category also includes growth hormone fragments, releasing hormones, and all analogues, as well as growth hormone secretagogues and growth hormone releasing peptides. Many of these substances are still under clinical investigation for conditions like weight management and growth disorders. The side effects of growth hormone use can include fluid retention, electrolyte imbalance, musculoskeletal disorders, and diabetes. At very high doses, it can lead to acromegaly, which is characterized by enlarged hands, feet, and facial features, as well as diabetes, cardiovascular disease, muscle and joint pain, hypertension, and accelerated osteoarthritis. On the screen, you can see a number of other growth factors and growth factor modulators. I won't go through them all in detail, as you are unlikely to be prescribing most of them in the context of treating athletes, but they cover a wide range of pharmacological actions. However, I will point out one notable substance in this category is platelet-derived preparations, or PRP, which is a treatment used in sports medicine to accelerate the healing of injuries like tendinitis, ligament sprains, and muscle tears by promoting tissue repair and reducing inflammation. Now, these involve concentrated growth factors derived from the blood and were previously on the prohibited list. However, after further research by WADA, PRP was removed as studies showed that there was no performance-enhancing effects beyond its therapeutic benefits. Moving on, we have beta-2 agonists, which stimulate beta-2 adrenoreceptors, leading to bronchodilation, vasodilation, and glycogen breakdown. Now, these are primarily used in the treatment of asthma and COPD and are commonly prescribed as asthma inhalers. While these substances are effective bronchodilators for treating asthma, their misuse in high doses can lead to significant ergogenic, or that's performance-enhancing benefits. Beta-2 agonists are therefore prohibited in sports in higher doses due to potential anabolic effects, which may lead to increased muscle strength and reduced body fat. The prohibited beta-2 agonists include many common medications, including short-acting drugs such as salbutamol and terbutaline, long-acting options like formoterol and salmeterol, and ultra-long-acting ones such as indacarol, vilanterol, and olodaterol. There is also a non-selective beta agonist, hygenamine, which has been reported to be found in certain weight loss supplements. This has caught a number of athletes out as they tested positive after taking such supplements. Side effects when doping with these drugs at high doses may include cardiac issues, hypertension, aneurysm, hypothyroidism, and diabetes. It's the higher doses that are the problem, both in terms of potential performance-enhancing effects and also the risks to health. And this is why WADA has developed clear thresholds to generally allow normal inhaled and therapeutic use of many of the licensed medications, while prohibiting higher doses. Now here's a breakdown of the permitted doses. For inhaled salbutamol, an athlete may use up to 1,600 micrograms over a 24-hour period, but any single 8-hour window must not exceed 600 micrograms. For inhaled formoterol, the maximum allowed delivered dose is 54 micrograms over 24 hours, with no more than 36 micrograms in any 12-hour period. For inhaled salmeterol, the permitted dose is up to 200 micrograms over 24 hours. And for inhaled vilanterol, the maximum is 25 micrograms over a 24-hour period. Now, what does this mean for you as a prescribing physician? Well, essentially, when we are considering beta-2 agonist for an athlete, it's crucial to firstly confirm the formulation. These exceptions only apply to inhaled products. If the beta-2 agonist is administered by any other route, say oral or systemic, these dose limits do not apply and the substance would remain prohibited. Secondly, it's important to adhere to these dosage limits. You must make sure that the prescribed dose does not exceed these maximum thresholds. Even a slight overstep in dosing could lead to an adverse finding under WADA's rules, potentially jeopardizing the athlete's career. Lastly, I always advise prescribers to keep detailed records of all the doses and prescribed and your administration directions. This documentation is essential if the athlete is ever subject to doping control and an investigation procedure, as it verifies that the use was within the permissible limits for legitimate medical purposes. Make sure that you also inform your athlete patients about these limits. Ensure that they understand that exceeding these doses, even unintentionally, can result in a doping violation. Let's look closely at the example of a formoterol inhaler. It is prohibited to use more than 36 micrograms in any 12-hour period, starting from any dose. In addition, the overall maximum of 54 micrograms in 24 hours cannot be exceeded without the need for a therapeutic use exemption. So what does this mean in practice? Well, say you have a product that has 12 micrograms per dose, which many do. That will mean 3 puffs, or 3 doses, as the maximum that can be used over 12 hours. But in addition, you can't use more than 4.5 puffs in 24 hours. Using 5 puffs would be considered prohibited. Now, some patients may actually need higher doses for their medical treatment, and if they do, well, then they can apply for a therapeutic use exemption to enable them to do so. I should note that these 12-hourly dosing intervals are pretty consistent with the manufacturer's recommended use anyway. There's one particular point I want to highlight. You'll notice that for formoterol on the prohibited list, it describes the maximum dosages in terms of the delivered dose. It is important to understand this term when assessing different products and to know the difference between the term delivered dose and the term metered dose. For example, when looking at inhaler products, you might see different values listed on the labels for the same medication. This is because some inhalers are labelled based on the metered dose, while others refer to the delivered dose. The metered dose is the total amount in the drug reservoir or the canister, whereas the delivered dose is what actually reaches the patient after passing through the mouthpiece. You can see an example of this on the screen with 2 similar formoterol inhalers. The one on the left is labelled as containing 6 micrograms per meter dose, while the example on the right is labelled as 4.5 micrograms per delivered dose. Now, in practice, the patient would use the inhalers in the same way for the same effect, but this point is really very important to understand when interpreting the wording in the wider prohibited list, so you can explain this to your patients. The same applies to metered dose inhalers. If you look at the standard salbutamol inhaler, which is a very common medication, the drug reservoir or the canister releases 100 micrograms per actuation. But once it passes through the mouthpiece, the delivered dose is actually 90 micrograms. Again, this variation in labelling is important for us to be aware of when advising athletes and prescribing medications, since WADA's limits are based on delivered doses. So it's crucial that both the prescribers and the athletes carefully read the product label and the accompanying information to ensure that they comply with these regulations. Misinterpretation of this dose could inadvertently perhaps lead to an anti-doping rule violation. So my key recommendation is this: always check how the dose is labelled, and if there's any uncertainty, refer to the inhaler's product information to clarify whether the value listed is the metered or the delivered dose. Now let's look at hormone and metabolic modulators in the S4 category. This group includes aromatase inhibitors as well as anti-estrogenic substances, most notably the selective estrogen receptor modulators, or SERMs. The abuse of these substances typically centres on their ability to manipulate estrogen levels, which in turn can elevate testosterone levels. And here's how they work. Aromatase inhibitors work by inhibiting the aromatase enzyme. Normally, this enzyme converts testosterone into estrogen, but by blocking this conversion, aromatase inhibitors help maintain higher testosterone levels. SERMs, or the selective estrogen receptor modulators, bind to estrogen receptors in tissues and can block the effects of estrogen. An important example is clomiphene. Now, clomiphene not only blocks estrogen's effects, but it also interferes with the negative feedback loop in the hypothalamic pituitary gonadal axis. Now, these interference can result in altered testosterone production, which is why clomiphene is sometimes considered or sometimes used in doping regimens to prolong the effects of androgenic agents. Now, it's important to remember that while these substances have been misused with the intention of enhancing performance, they also have legitimate medical applications. They're used, for example, in chemotherapy protocols and in treating fertility issues in gynecological practice. In terms of potential side effects associated with their misuse, this can include hormonal imbalances, fertility issues, fluid retention, reduction in bone density, and adverse impacts on liver enzymes. Now I want to move on to the next subsection, agents preventing activin receptor 2B activation. There are several substances within this category, but I want to focus specifically on myostatin inhibitors. Myostatin inhibitors work by blocking the action of myostatin, a growth factor which is responsible for limiting muscle growth. When myostatin is inhibited, the muscle mass increases significantly, making these substances highly relevant in the context of sports performance and anti-doping. Many of these inhibitors have been under development for medical applications, particularly in the treatment of muscle wasting disease, such as muscular dystrophy. However, to date, none of them have actually been approved as medications. Now let's move on to the last subclass of metabolic modulators. This category includes AMP-activated protein kinase activators, such as ACAR and PPAR, delta agonists, with the most well-known being GW1516. Starting with ACAR, this substance is currently under investigation for its potential role in protecting cells against oxidative damage. And GW1516 is being explored in clinical trials for conditions like diabetes and metabolic syndrome. It is believed to work by stimulating fatty acid oxidation, increasing glucose uptake in skeletal muscle, and shifting metabolism to prioritize fat burning over carbohydrates or muscle tissue for energy. Another key part of this category is insulin and insulin mimetics, which are included due to their role in energy metabolism and their potential anabolic effects. Now, this category is particularly important to consider if you are prescribing for diabetic athletes, because all insulin-dependent diabetics who require insulin, or any athlete using insulin mimetics, must apply for a therapeutic use exemption, TUE. The process for applying for these will be covered in another presentation. Additionally, meldonium and trimetazidine are listed due to their cardiac stimulating properties. Now, meldonium is used in some countries, but mainly in Eastern Europe. It's sometimes also available over the counter in some countries. It's used as a tonic or a cardiac stimulant, while trimetazidine is an approved medicine for treating heart disease and angina. We have seen a number of high-profile athletes test positive for these substances in recent years, with very severe sanctions after taking these prescribed medications on recommendation from their physician. This is another reason why you, as a prescriber, must be closely aware of the status of every medication that you prescribe or administer to athletes. Now let's move on to the next section, masking agents. Masking agents are substances that are misused in sport to conceal the presence of other prohibited substances and interfere with drug detection. This category includes diuretics, desmopressin, plasma expanders, and probenecid. Diuretics promote the excretion of water and electrolytes via the kidneys and are widely used in medical treatment for conditions such as cardiac issues, hypertension, and uremia. Spironolactone, for example, is used for polycystic ovarian syndrome. Desmopressin is typically prescribed for nocturnal enuresis or bedwetting. Plasma expanders, these are used in cases of hemorrhage or shock, but from an anti-doping perspective, they are prohibited because they increase blood volume, which can effectively dilute the concentration of prohibited substances in the bloodstream, making detection more difficult. Probenecid inhibits renal transporters, meaning that it can slow the excretion of certain drugs, including anabolic agents. Now, this makes it a recognised masking agent, particularly for steroid abuse. In some countries, probenecid is still used medically, and it could be prescribed to increase the concentration of antibiotics, such as penicillin, in the body. While most masking agents are prohibited, there are a few important exceptions. Right. Firstly, drospirenone, which is found in many oral contraceptives, is permitted. And pamabron, which is present in some over-the-counter medications for premenstrual tension or syndrome, is also permitted. Topical or ophthalmic administration of carbonic anhydrase inhibitors, such as dorzolamide or brinzolamide, is also permitted. Now, these substances are used in eye drops to reduce intraocular pressure in conditions like glaucoma. Now, while carbonic anhydrase inhibitors are considered diuretics, when used in eye drops, their systemic absorption is very minimal, meaning they are allowed as an exception. They're permitted in sport as an eye drop. So again, this section has some frequently prescribed medications that you really must be aware of when prescribing for athletes, and the nuances that exist in the various formulations. I want to highlight an important point about double therapeutic use exemptions for certain medications. Now, this applies to formoterol, salbutamol, caffeine, ephedrine, methylephedrine, and pseudoephedrine. Now, these are known as threshold substances. So just to explain what a threshold substance is, a threshold substance is a drug that is allowed up to a certain concentration in the urine. If an athlete's sample exceeds this limit, it is considered a positive test, unless they have a valid therapeutic use exemption to justify the dosage. And so why would a double TUE be needed? Well, if an athlete has a TUE for a diuretic, which is classified as a masking agent, and they also need to use a threshold substance, they must apply for a second TUE for that threshold substance. Now, this is because diuretics affect urine concentration by increasing the fluid excretion, which can alter the levels of threshold substances in a doping test. This means that the usual threshold limits no longer provide an accurate measure of whether the substance was used within the allowed dose. The thing to remember is that if an athlete uses both a diuretic and a threshold substance, they must apply for two separate TUEs, one for the diuretic and another for the threshold substance. Please do take some time to read about and properly understand this concept. It is contained within the note section at the end of the S5 category on the prohibited list. It's very easy to miss, but it's something that all physicians treating athletes should be aware of. Let's now cover sections M1, M2, and M3 of the prohibited list, all of which describe prohibited methods. Firstly, section M1. This is manipulation of blood and blood components. This is broken into three concepts: the manipulation or administration of blood and blood components, as well as artificial enhancement of oxygen transport, and intravascular blood manipulation. So firstly, blood manipulation. Now, this is also commonly known as blood doping. Now, we've already talked about EPO, erythropoietin, and how it enhances red blood cell production with the effect of boosting endurance. But blood doping existed long before EPO was ever available, and it involves the physical manipulation of blood, including the administration of blood transfusions to artificially increase oxygen levels and improve performance. Now, blood doping is associated with serious health risks, including risk of infections such as HIV, hepatitis, increased red blood cell counts, which raises the risk of heart disease, stroke, pulmonary embolism, or cerebral embolism, or blood type mismatches leading to dangerous potential immune reactions. The second prohibited method is artificially enhancing oxygen delivery using synthetic oxygen carriers. Now, these substances were originally developed for medical use in cases of severe blood loss, but in sport they are misused to increase oxygen transport and obviously endurance performance. Again, the risks are significant. They can include stroke, heart attacks, and embolism. One important clarification here, that is that inhaled supplemental oxygen is not prohibited. Now, this is a common question, and it's essential that we differentiate between oxygen therapy for medical reasons, which is permitted, and oxygen carriers, which is used to manipulate performance, and these are banned. The third method here is intravascular manipulation of blood or blood components using physical or chemical means. Now, this means that even if blood is not removed from the body, it is still considered prohibited if it is being manipulated in any way. For example, closed-circuit blood filtration or modification, where blood is taken, altered, and returned to the body. Now, this is still banned under anti-doping regulations. I just want to further explain the wording on the prohibited list relating to apheresis. Now, this was added for the 2025 version of the prohibited list. If you refer to section M1.1, you will see it has a note that says donation of blood or blood components, including by apheresis, is not prohibited when performed in a collection centre accredited by the relevant regulatory authority of the country which it operates. In other words, apheresis is a specific medical procedure that is permitted for athletes as a way of donating blood components. Now, to explain the term apheresis, apheresis involves separating and collecting particular blood components such as plasma or platelets while returning the rest of the blood to the donor's body. So this allows donors to give targeted components without needing to donate all of their blood or a large volume of blood, making it a very efficient donation method. Now let's move on to the second prohibited method, chemical and physical manipulation. This category covers tampering with doping control samples and restrictions on intravenous infusions and injections. These are important considerations for you as sports physicians because they directly impact how treatments are administered and how doping control samples are handled. The first part of this category includes tampering or attempting to tamper with doping control procedures. Now, this can involve urine substitution. This is where an athlete provides somebody else's urine instead of their own, or the use of proteases for adulteration, for example, using washing powder or other substances to add to a urine sample to break down or destroy a sample before it is sent to the laboratory for testing. The second part of this category places strict limits on intravenous infusions and injections. which is important to know when treating athletes. Basically, administrations of IV infusions of more than 100 mils within a 12-hour period are prohibited unless that they are legitimately received as part of hospital treatment, a surgical procedure, or a clinical diagnostic investigation. Now, this means that even if a medication itself is not prohibited, for example, an IV infusion of antibiotics, it would still be considered a doping violation if the volume exceeded 100 ml within a 12-hour period. And the location and context of the IV treatment matter just as much as the substance itself. Now, if it's an emergency situation where the athlete patient needs urgent treatment with a high volume infusion or a prohibited drug, then this should never be withheld. In this situation, the athlete's health remains absolute priority and the necessary treatment should be provided for emergency care. Now, there is a mechanism for this which is called a retroactive TUE, and this can be applied for in this setting, which will be covered separately in this program, and I'll mention it a little bit later in this lecture as well. The final prohibited method I want to discuss is gene and cell doping. Now, this is a rapidly evolving area in both medicine and biotechnology. And while its widespread use in sport is not currently confirmed, it is a serious concern for the future of anti-doping regulations. Gene and cell doping refers to the use of genetic or cellular modifications to enhance athletic performance. Now, this can include gene editing, gene silencing, and gene transfer. For example, technologies which can modify DNA sequences. These are prohibited if they have the potential to enhance performance, or when gene editing might be used to alter muscle growth, endurance, or recovery, obviously giving an unfair advantage. And use of normal or genetically modified cells. Now, this covers cell-based therapies where modified or unmodified cells are introduced into the body to enhance performance. For example, increasing oxygen carrying capacity or stimulating muscle regeneration beyond the athlete's natural limits. Okay, so the next major section of the prohibited list covers those substances that are only prohibited in competition. Let's start with clarifying the definition of the in-competition period according to the World Anti-Doping Code and how it applies in different sports. Now, this time frame is crucial because it determines when certain substances are prohibited and how doping violations are assessed. As I mentioned before, the in-competition period begins at 11:59 p.m. the day before an athlete is scheduled to compete, and it lasts until the end of the competition and any sample collection process if that is undertaken. Now, this is the definition used by the International Olympic Committee, both the Summer and Winter Olympic Games and Youth Olympic Games, and it applies to all sports at those games. And so any substance that is only prohibited in competition, such as certain stimulants, narcotics, or glucocorticoids, is allowed outside of this period, but could result in a violation if detected within this period. WADA allows some flexibility of this definition for certain sports. If an international federation provides a compelling justification, WADA may approve a different in-competition period. So it is always important to check the International Federation rules of the sport in case there are variations to this. Now, a few examples of the WADA-approved variations to the standard definition can be seen here on the screen, such as the Equestrian Federation. The in-competition period begins 1 hour before the first horse inspection on the day before the competition, and it concludes after the athlete's final competition or related sample collection. For the Motorsports Federation, it starts when the rider has passed the technical or administrative scrutineering before the competition they're scheduled to participate in, and it ends after that competition and any associated sample collection. For the International Cricket Council, the in-competition timeframe commences at 11:59 p.m. local time, the day before the first day of an international match, and continues through the match's completion and the related sample collection. Now you can find the complete list of these exceptions on the WADA website. Again, if you are working with athletes at a particular event, always know what definition applies so that you can provide accurate guidance to the athletes you treat. The prohibited list includes a section on stimulants, which are banned in sport mainly due to their performance-enhancing effects, which can include increased alertness, reduced fatigue, and enhanced focus. But beyond their performance-enhancing effects, stimulants used by athletes can carry significant health risks. They can increase heart rate and blood pressure, potentially raising the risk of cardiac events, especially in high-intensity sports where the cardiovascular system is already under considerable strain. Stimulants can also cause insomnia, anxiety, agitation, and in some cases dependency or withdrawal symptoms. Dehydration and heat-related illnesses are additional concerns, as stimulants can impair an athlete's ability to regulate their body temperature effectively. In extreme cases, stimulant abuse has been linked to life-threatening arrhythmias and sudden cardiac death, particularly in those with undiagnosed cardiovascular conditions. The abuse of stimulants is more prevalent in sports that demand endurance, intense focus, or explosive power, and where the reduced fatigue and heightened reaction times provide a competitive advantage. Stimulants are also known to be misused in sports that require sustained attention, such as motor racing or esports, that is gaming. And in team sports, they may be used to counteract fatigue during long matches or tournaments. They are broken into two categories: specified and non-specified stimulants. As I mentioned earlier, specified stimulants are those that WADA considers to have a lower risk of abuse in sport. Now, these substances may still be prohibited, but their classification allows for some degree of leniency in anti-doping law violations. In contrast, the non-specified stimulants carry a higher potential for abuse, and their presence in an athlete's sample leads to more severe sanctions, with fewer opportunities for a reduced penalty. So on the screen you can see that drugs like amphetamine and cocaine are in this grouping. Stimulants are prescribed for conditions such as attention deficit hyperactivity disorder or ADHD and narcolepsy, with medications such as methylphenidate and amphetamine derivatives. If a prohibited stimulant is medically necessary, athletes must apply for a therapeutic use exemption, and for chronic conditions, these may be granted for a number of years. In the specified section, you have a mix of different drugs and metabolites. You can see that ephedrine is prohibited, which can be found in some over-the-counter preparations in some countries. I also wanted to point out an exception for the drug epinephrine or adrenaline. Now, the exception is that if adrenaline is used via local administration, for example intranasal or ophthalmological, or co-administration with local anesthetic agents, then is not prohibited. Now, as an example, the picture on the screen shows a lidocaine and adrenaline injection Now, if this is administered locally, it's not prohibited. And this might be in the context of, say, a local, or a dental procedure. The stimulant list is very long, and it continues here. And we have more here. Over-the-counter medications pose a big challenge, as many contain stimulants that athletes and even some healthcare providers may not immediately recognise as prohibited. I want to point out that the stimulant list includes pseudoephedrine, which is a common over-the-counter drug used for sinus and runny nose. But there is a condition that it is only prohibited if it's found to be above the concentration of 150 micrograms per ml in urine. WADA recommends that athletes should stop taking pseudoephedrine-containing medicines at least 24 hours before competition, so that this level above 150 micrograms per ml in their urine is not encountered. The alternative is, of course, to select a different treatment option that is not prohibited for the same indication, such as phenylephrine. Now take some time to read the frequently asked questions section on the WADA website that describes this in detail. There are some more exceptions that I want to point out, including clonidine, imidazoline derivatives for dermatological, nasal, otic, or ophthalmic use. Now these include brimonidine, clonazepam, phenoxazepine, indanazoline, tetrazoline, nafazoline, oxymetazoline, and xylometazoline. Now, in addition, the stimulants on the monitoring program are not prohibited. Now, these include bupropion, caffeine, nicotine, phenylephrine, phenylpropanolamine, and there's a few others. I want to make one point to consider when assessing medications. The same brand can in fact have different drugs with different status. The Sudafed product on the right contains phenylephrine, which is permitted, and the Sudafed product on the left contains pseudoephedrine, which is prohibited above certain concentrations. Another example, these two Vicks vapohalers were bought in different countries. The product on the left is available in the United States. It contains lev-methamphetamine, which is prohibited. And the one on the right is available in the United Kingdom, and this contains menthol, which is permitted. Now, these differences have caught many athletes out over the years and have resulted in disqualification and even Olympic medals being stripped. When treating athletes, you are in the position to be able to provide education about these differences, to make them aware of things they need to keep an eye out for, particularly when they're travelling, to help them avoid a positive doping test. The prohibited list includes narcotics, which are banned in competition due to their effect on pain perception, cognitive function, and overall athlete safety. Narcotics, they're also known as opioids, include medications such as morphine, fentanyl, oxycodone, hydromorphone, methadone, and heroin. Now, these drugs are potent analgesics that act on the central nervous system to relieve pain. The prohibition of narcotics in sport is primarily due to their potential to mask pain from injuries, which can lead to further harm by allowing athletes to continue despite potentially serious underlying conditions. Additionally, their sedative effects can impair coordination, reaction time, cognitive function, obviously posing risks in sports requiring quick decision-making or precise motor skills. From a prescribing standpoint, narcotics are most commonly used in the treatment of acute pain following sports injury, as well as in cases of severe chronic pain where alternative treatments are insufficient. Now, if an athlete requires pain management with opioid analgesics, careful consideration should be given as to whether a permitted medication could be used instead. If no suitable alternative exists, well then a therapeutic use exemption must be applied for to ensure compliance within the anti-doping regulations. Strong opioid analgesics are often used in the emergency setting, such as a severe painful injury on the field of play. And if this is the case, then a retroactive TUE can be applied for after the emergency case has been resolved. The health risks associated with narcotic use is one of the other reasons why they're on the list. Now, these drugs have high potential for dependence and addiction, and their misuse can lead to tolerance, withdrawal symptoms, potentially overdose, and they can also negatively impact performance and recovery. I just want to take this opportunity to remind you about an important change that happened in very recent years. Tramadol has been prohibited in sport during the in-competition period since January 2024, and it continues to be prohibited. As you all know, tramadol is a common prescription medicine used for severe, painful sports injuries and other injuries. It's often carried by team doctors for administration, in the emergency setting. Like the other opioids, tramadol can mask pain, and it was known to have been particularly abused in sports such as cycling and rugby. Now, over a number of years, the WADA monitoring program also indicated significant tramadol use in sports including cycling, rugby, and also football. Now, there was a study by the World Anti-Doping Agency in 2023, and this showed that tramadol does actually have the potential to improve performance, and so for this reason it was banned. Now, this does not mean that this drug cannot be used medically for legitimate pain relief, but it just means that if you need this for an athlete, you'll have to apply for a TUE. And if needed in an emergency situation, then a retroactive TUE is needed. As a prescriber at a sporting event, it is worth considering what would be your go-to choice for emergency analgesia, perhaps for an athlete on the field of play. An example of a permitted option is methoxyflurane, which is a potent inhaled anesthetic. Now, this provides rapid and a very effective short-term pain relief, making it an excellent option for acute injuries on the field of play. This self-administered inhaler is easy to use, it's non-invasive, with the effects kicking in within minutes. Certainly one to look up and consider whether this might be something that you could prescribe in this for this use. Now, ketamine injection might be another permitted option to consider. Ketamine is a powerful NMDA receptor antagonist used for its analgesic and sedative properties. Now, on the field of play, ketamine can be administered via intravenous or intramuscular routes, providing rapid pain relief, and it can be a decent option for severe injuries where immediate pain management is critical. However, ketamine can produce psychotropic effects such as hallucination, and so there's careful monitoring needs to be in place, and the dosing needs to be administered by trained medical professionals with experience of this drug. Its rapid action and the effectiveness makes it a potentially useful option in your medicines bag for prescribing during sporting events. So these are just a couple of examples of permitted alternatives. You might also consider injectable non-steroidal anti-inflammatory drugs, NSAIDs, for perhaps injectable paracetamol or acetaminophen, all which give good, fast analgesia. Of course, your decision will be individual for that patient based on the injury and degree of pain that they're experiencing. Next, on to section S9, cannabinoids. Now, interestingly, cannabis is the most commonly used drug in the world after alcohol. The prohibited list includes all natural and synthetic cannabinoids, except for cannabidiol, or also known as CBD. This means that substances such as cannabis, hashish, marijuana, and the active ingredient THC, whether from natural sources or synthetic formulations, are prohibited during competition. Now, importantly, CBD itself is not prohibited, but athletes should be advised that many of the CBD products can contain trace amounts of THC that could result in a positive test. One of the main reasons cannabinoids are prohibited is in relation to the well-documented health risks to athletes. These include cognitive impairment and mental health effects. Smoking or vaping cannabis products can also lead to respiratory issues. Now, their use may in fact result in performance decreasing or ergolytic effects. Cannabinoids can impair reaction time, coordination, decision-making, which as well could pose safety risks, particularly in sports requiring rapid responses or precise motor control. But there really is a mixed perspective on whether cannabinoids enhance performance. There are studies to suggest that the reduction in pain and the reduction in anxiety experienced may contribute to performance enhancement. And many athletes report benefits in the recovery process after training or competition when using cannabis. It's well known that certain sports may have a higher prevalence of cannabis use, and this is often influenced by cultural attitudes or the nature of the sport. Now, these include urban sports or extreme sports, such as snowboarding, skateboarding, surfing, where cannabis use is sometimes perceived as part of the lifestyle of those athletes. From a prescribing perspective, cannabinoids are sometimes used therapeutically by athletes for chronic pain or neuropathic pain. Now, a TUE might be applied for, but you would have to demonstrate that there are no permitted alternatives. And in most cases, for an athlete, there usually are suitable permitted alternatives than medical cannabis. In saying that, I have occasionally seen TUEs issued for medical cannabis products. The prohibited list includes glucocorticoids, which are banned in competition when administered via certain routes. They're also one of the most commonly used class of medicines for inflammatory musculoskeletal conditions in athletes. Glucocorticoids include a range of drugs such as prednisone, dexamethasone, betamethasone, triamcinolone, and hydrocortisone. They are potent anti-inflammatory and immunosuppressive agents. They're used to treat a wide range of conditions, including asthma, allergic reactions, and potentially autoimmune diseases. For musculoskeletal injuries, they can be effective for a fast reduction in inflammation, and this could potentially lead to pain relief, and a significant improvement in joint function and motion. Glucocorticoids are prohibited in competition when administered via systemic routes, and specifically oral, rectal, or any injectable route. Now, the injectable routes could include intravenous, intramuscular, and all local injections, including intra-articular, periarticular, and peritendinous injections. As examples, on the screen we have triamcinolone injection, prednisolone oral tablets, and hydrocortisone rectal suppositories. These are prohibited. Other routes, such as inhalation and topical routes of administration, are permitted. Now here are some examples of permitted products. Inhaled beclomethasone, which is used for asthma prevention. Hydrocortisone topical cream, which is used for dermatological conditions. Prednisolone eye drops, which are considered topical use. Mometasone intranasal spray. And hydrocortisone cream when used for perianal application. Now, intracanal use, that is into the tooth during dental procedures, is also permitted. I should note that other uses of glucocorticoids in the mouth, such as oral creams or gels or buccal applications, are considered prohibited under the oral classification. For you as a prescribing physician, understanding washout periods for glucocorticoids is extremely important. So let me briefly explain the concept. If systemic glucocorticoids are medically necessary in the lead up to competition, you must consider whether the treatment can be concluded in time for the substance to clear the athlete's system, so that they don't test positive during the in-competition period. After administration of glucocorticoids, urinary reporting levels, which would result in an adverse analytical finding or a positive doping test, can be reached for different periods of time after administration. This can range from days to weeks, depending on the type of glucocorticoid administered, the route of administration, and the dose given. And so to reduce the risk of an adverse analytical finding, you should follow the minimum washout periods. Now, a washout period refers to the time from the last administered dose to the time of the start of the in-competition period. This is to allow elimination of the glucocorticoid to below the laboratory reporting level. This table shows the washout periods for various glucocorticoids. You can see that the washout varies from 3 days right up to 60 days, depending on the drug and the route of administration. For example, local injections of triamcinolone have a washout period of 10 days. Local injections of other glucocorticoids, such as betamethasone, have a washout period of just 3 days. So with all these washout periods now clearly defined, clinicians have much more information to base decisions regarding the selection of different types of glucocorticoids for athlete treatment. You can see helpful guidance for oral and intramuscular routes of administration are provided on this table as well. I should note that these washout periods are based on the use of these medications according to the manufacturer's license doses. So in principle, if the glucocorticoid needs to be administered via prohibited route within these washout periods, a TUE may be required. The most up-to-date washout period guidance is on the WADA website, and I really urge you to take a look at that and study this concept, particularly if you're working currently with athletes. The very last section of the prohibited list refers to substances which are only prohibited in certain sports. At the moment, the only class of drugs in this section are beta blockers. Beta blockers include common medications such as propranolol, atenolol, metoprolol, bisoprolol, and carvedilol, which are used to manage cardiovascular conditions such as hypertension, angina, arrhythmias, and heart failure. They work by blocking beta-adrenergic receptors, reducing the heart rate, reducing blood pressure and tremors, while also mitigating the effects of anxiety. Their performance-influencing properties are particularly relevant in sports requiring fine motor control or steady hand movements, and a reduced physiological stress response. As such, they are prohibited in archery, automobile, billiards, darts, golf and mini-golf, shooting and underwater sports. So if the athletes you are treating compete in any of these sports, these medications will be prohibited for them during the in-competition period. I want to briefly discuss substances of abuse. This was a category introduced in the 2021 prohibited list. These substances are included in this special subcategory because they're frequently abused in society outside of the sporting context, such as recreationally or socially. In identifying substances of abuse, the primary objective of WADA was to distinguish out-of-competition, non-sporting abuse from sport-related use in the context of an intention to improve performance. Now, under Article 10.2.4.1 of the World Anti-Doping Code, if an athlete can prove that the use of that substance occurred out of competition and was unrelated to performance enhancement, they will face a 3-month sanction. Now, this 3-month sanction can be further reduced to 1 month if they complete a recognised substance of abuse treatment program. So take some time to read in full these sections describing this substance of abuse category within the full World Anti-Doping Code, which can be downloaded from the WADA website. As of the 2021 prohibited list, 4 substances were designated as substances of abuse, and they sit in different categories on the prohibited list, but they share this common designation. And these are cocaine and MDMA, or ecstasy. These are both stimulants. Heroin, which sits in the narcotic category, and tetrahydrocannabinol, or THC, which is the active component in cannabis. Now, this category may expand and evolve over time as more substances are reviewed, so it's certainly one to watch. Next, I want to briefly discuss the WADA monitoring program, which monitors or tracks the use of substances that are not currently prohibited, but may potentially be misused in sport. The WADA monitoring program is based on Article 4.5 of the World Anti-Doping Code and helps to identify trends that could influence future anti-doping regulations. The monitoring program list contains a small number of specific substances under investigation. There's about a dozen or so. The WADA asks the laboratories to test for when they're doing routine screening. Now, a key point that you may be asked by an athlete is that the detection of a WADA monitored substance is not an anti-doping rule violation. The monitoring program tracks the use of substances in and out of competition, but the goal is to analyse patterns of use and determine whether any should be added to the prohibited list in the future. Anonymous data is collected by the WADA accredited laboratories around the world, and it's reviewed by WADA's prohibited list expert group, which assesses trends and potential misuse and looks at all the other evidence that's gathered for a particular substance. For you as sports physicians, this means that you need to stay informed. While substances on the monitoring program are not currently banned, their status could very well change. Some may become prohibited as more information is gathered. For example, meldonium was on the monitoring program for a number of years, but was subsequently designated as prohibited, and now it sits on the list. Please do take some time to read through the current WADA monitoring program list, which is available on the WADA website. It is just a one-page document, but be sure to look for any therapeutic medications that are currently being monitored so you can keep an eye on whether their status changes to potentially being prohibited in the future. Now, I've mentioned it previously, but I want to reiterate a note regarding the use of prohibited medications during emergency treatment. Now, in the event of a medical emergency, your primary responsibility is to safeguard the athlete's health, even if this necessitates the use of substances or methods that are otherwise prohibited. In such critical situations, immediate and appropriate medical intervention must take absolute precedence over checking whether the drug is on the prohibited list to ensure the athlete's safety and to potentially save their life. However, once the emergency has been managed, it is important to apply for a therapeutic use exemption, retroactively providing comprehensive medical justification for the need for that intervention. Thorough documentation will be essential to demonstrate that that treatment was necessary and that was conducted in accordance with medical best practices. Again, this will be covered more in detail in the TUE presentation of this course. I just want to talk a little about supplements, although this will be covered in depth in other presentations. As a sports physician, you must be acutely aware of the complexities surrounding supplement use in athletes, as they are used by a large proportion of the athlete population for performance, recovery, and general health. However, the supplement industry is not uniformly regulated worldwide, and manufacturing inconsistencies, cross-contamination, and misleading labeling can result in the presence of prohibited substances in supplement products. Athletes are ultimately responsible for what enters their bodies, and inadvertent doping due to contaminated supplements remains a significant risk, with numerous doping violations traced back to supplement use. While certain quality assurance programs such as third-party testing and certification schemes can certainly help reduce the likelihood of contamination, they do not completely remove the risks. Sports physicians should guide athletes in critically evaluating the necessity of supplementation, encouraging a food-first approach where possible, and recommending only verified products when supplementation is deemed essential. Educating athletes on the risks, proper supplement selection, and the importance of strict due diligence is crucial in minimizing the potential for unintentional anti-doping rule violations. So I know there is a lot to take in here, but you will be pleased to hear that there is a lot of resources out there to help you. A very good resource is globaldro.com. If you live in Canada, United Kingdom, USA, Switzerland, Japan, Australia or New Zealand, you can search for the brand names of medicines in your countries. But an athlete or healthcare provider in any country can look up the status of an ingredient or a generic drug name, or find the links to other international websites with information specific to your country. I would encourage you to check this out if you haven't already. It's an excellent resource to give to the athletes you are treating and to have to hand when you're prescribing. National anti-doping organisations also often have information lines or resources localised for different regions, so be sure to check out the anti-doping organisations in your area. Just to illustrate a Global Dro search, here is a screenshot of a Global Dro search for amphetamine. You can see it's clearly indicated as prohibited in competition, but not prohibited during the out of competition period. So that brings us to the end of this presentation. As we wrap up, it's important to remember your responsibilities as sports physicians regarding the WADA prohibited list. The list is updated annually, and staying informed helps ensure compliance and protects your athletes. Be sure to always keep a copy of the prohibited list to hand and any local resources that may be available to you through your national anti-doping agency. Your role as a sports physician is also to advise athletes on safe and effective and permitted treatment options and remind them of their responsibility for what they take and that they are responsible for what they put in their system. With that in mind, I hope this has been informative for your role in anti-doping and clean sport. I've included some links to further reading and resources on this topic in the accompanying materials, so be sure to check them out. Lastly, if you ever have any doubts, always refer to the latest prohibited list and seek guidance from your national anti-doping agency. Thank you.